The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today will discuss how neuropathologists generate rapid diagnoses during surgery. My name is Jennifer Westland. I'm the Associate Director of National Programs and Services here at the American Brain Tumor Association. And I'm really excited to introduce one of my favorite speakers today, Dr. Craig Horbinski. A native of Buffalo, New York, Dr. Horbinski did his undergraduate training in biology at Canisius College and a combined MD-PhD at the State University of New York at Buffalo. Upon completion of his neuropathology fellowship in July 2009, Dr. Horbinski joined the faculty at the University of Kentucky in Lexington as an assistant professor in neuropathology, where he is continuing his work on glioma biology and molecular diagnostics as an NIH-funded independent principal investigator. Dr. Horbinski is the Director of Molecular Anatomic Pathology, the Director of the Markey Cancer Center Biospecimen Core, and he's also the founder and director of the University of Kentucky Brain Tumor Bank. To date, he has published nearly 50 original papers and reviews, several of which have received special recognition for being highly cited. So with that, I'm so delighted to ask Dr. Horbinski to join us today. You may go ahead and begin your presentation. Thanks for being here.
Thanks very much, Jennifer, and thanks to the American Brain Tumor Association for giving me the opportunity to deliver this webinar, and thanks to everybody for tuning in. So this is the title of my talk, How Neuropathologists Generate Rapid Diagnoses During Surgery. This, in case you're curious, is what I actually look like, because otherwise you're just going to be hearing a disembodied voice. To my family tuning in, you probably still remember what I look like. Now, the topics we're going to cover is, first of all, what an intraoperative consult actually is, how it's done, and in particular, I'm going to show you a couple of videos of me doing a real-time intraoperative consultation, some examples of sort of classic tumors that we see and other types of disease processes that we see, and lastly, something I'm really, really excited about that's changing as we speak, is changing how we're practicing pathology. Telepathology, a new innovation that is going to alter how your care is delivered. So, intraoperative consults. Now, you all know, I'm sure, either you've been inside an OR or you've seen one on a TV show or a movie or something, so everybody's familiar with what an OR looks like, more or less. All the lights and all the equipment, it's a very scary place to be, especially if you happen to be a patient. It can be unnerving even for a doctor. So, from there, though, the tissue, what happens to the tissue after it's taken out of an operating room is a bit of a black box. Even to clinicians and nurses, they might not necessarily be fully aware of everything that has to go on behind the scenes. The tissue is taken out of the patient from the OR and is transferred, is couriered over to a laboratory called the Surgical Pathology Lab. This is also known as a gross lab, where the tissue is physically handled and studied and processed and put into these little samples of the tissue will be put into these little cassettes. These little cassettes right here with closable lids that are then placed in formalin fixation and go to a histology laboratory. From there, the tissue is placed on machines like this, embedded in paraffin wax with little pieces of tissue. This is the tumor tissue right here that's embedded in wax, and then it's put on something called a microtome that can cut sections very, very thin, about 4 to 5 microns, which means 4 to 5 millionths of a meter thick, that are translucent enough to put on glass slides, which are then stained with special dyes, and you can see them under the microscope and get a diagnosis. However, the only catch is this entire process from start to finish takes at least a day, maybe a day and a half, sometimes 2 days. For example, if we have a tumor here that comes out, say, late afternoon, 3 or 4 o'clock, that tissue is not going to get processed right away. It sits overnight in fixative. I want to eventually see that tissue with the glass slides under the permanent sections until Wednesday, maybe afternoon. But there's plenty of times during the actual surgery where the neurosurgeon needs to know immediately what he's dealing with for various reasons we'll get into. Now, in that case, it simply won't do to wait 1 or 2 full days, then by that point, of course, the patient's out of the OR and there's nothing else can be done. So what we'll do in cases like that, when the neurosurgeon requests it, is take the tissue, instead of putting it right into tissue cassettes into the histology lab, we'll stop right here and do a rapid intraoperative consultation. So there's 2 main reasons why it's needed, especially in the context of neurosurgery cases. The number 1 reason is that the neurosurgeon needs to verify that he or she has hit the targets that they were going for. Now, this is kind of unique to neuropathology and neurosurgery because, for example, in most cases, if you have a lung tumor or colon tumor or a breast tumor, it's really obvious where the tumor is. They usually already know what it is. And they're not so concerned about hitting the diagnostic tissue. They know they've got it. They're just trying to take it all out. But in the case of a brain, it's not like you can just crack open somebody's skull, reach in with your bare hand and pull it out. I mean, the brain is a very, very delicate structure. It's a lot more complicated. It can take hours just to obtain a several millimeters worth of diagnostic tissue. It depends on where that tumor is located. So they need to be certain that they've actually hit the target and then they have indeed obtained diagnostic tissue. If they have, then they can close up and they're confident they're good to go. So that's the main reason why a neurosurgeon would want an intraoperative consultation. Another one would be to dictate surgical approach. So this depends on what kind of, some kinds of tumors, if you can resect or take out the entire tumor, the patient's probably cured. And then there's other kinds of tumors and other kinds of diseases where you don't need to take out the entire diseased tissue. In fact, sometimes it's not good if you do. So in those kinds of cases, the neurosurgeon really wants to know, hey, should I proceed with getting this whole thing out or can I just stop? And as you might imagine, surgical approaches can vary. I would certainly hope that it doesn't include something like this. This would not be considered standard of care. All right, so here's how these things are done. There's 2 kinds of intraoperative preparations. There's the smear preparation and the frozen section. I'm going to show you, I'm going to click to a video here that is going to show a smear preparation. Now, there's a couple of caveats before we get started. First of all, as you can see, there's a little bit of blood. It's not that gory, but just be warned. And then second, when I was filming this myself in real time, I was doing an actual intraoperative consultation. I was actually narrating it, but I have to re-narrate it over because I had to turn the speakers off for this talk. So you'll see me making hand gestures and everything, but that's because I was actually talking while I was doing this. So here what we're seeing now is a tumor from a patient, a 70-year-old man who had lung cancer. Now he's got a tumor in his brain, which is probably metastatic disease. And we're looking at lung cancer right there. On the other side of that piece of tissue, I just flipped it over, and you can see a lot of blood in the tissue, as well as that spot right here is actually a little piece of gray matter. That's the cortex. Now we don't care about that. We're not trying to biopsy or study that part under the microscope. We want to make sure we have a diagnosis. So we're going after the, yes.
It's Jennifer. I'm sorry to interrupt you. Your video it does not appear to be working within your presentation. I don't know if you have the capacity to toggle between the video from another source, or if we should maybe skip this section.
Yeah, I'm seeing it on my computer. I guess it's not showing up on the video. Oh, but I'm very sorry about that. Well, in that case, I guess I better just cut it out.
I'm sorry. I'm not sure why it's not showing, because typically, whatever you're showing on your screen should come through without any issue, but that does not seem to be the case at the moment. I know you rehearsed it as such, but...
Okay, no problem. I'm very sorry about that, everybody. But
so sorry.
No, it's okay. Well, can you see the presentation now?
Yes, we can see the slide that says 2 kinds up at the top.
Yes.
Okay.
All right. Well, very, very sorry about that. It's the first time we've done video on a webinar, but I guess there's some bugs with it. Okay, so the smear preparation, basically what it entails is taking the tissue and smearing it on a glass slide and then quickly staining it and putting it under the microscope. And that takes maybe about 5 minutes. And so as you can see, it's pretty quick. And it can say if you have a lot of tissue to preserve, it says most of the tissue for better processing. You get a better look at cell details. The only catch is it does lose some information. You lose the overall architecture of the tumor. And if you sample the wrong area, you can be led down the wrong path as far as the diagnosis goes. And if the tissue is really stiff, some tumors are very firm or rubbery, and you just can't see it, or you just can't smear it very well at all. It just won't smear well. Whereas many other kinds of cancers are actually have more or less a consistency of applesauce, and they'll smear very nicely. So in cases like that, we'll actually do a frozen section. Do a frozen section takes a little bit longer, and it does blow through a lot of precious tissue, especially if the biopsy is small. It can be a downside. Some of the cellular details can be destroyed because you're rapidly freezing this thing, and it can wreck some of the microscopic details. On the other hand, it does better preserve the overall architecture, and you can actually see more areas of interest in these frozen sections compared to the smear preparation. And you can actually do it on all kinds of tissues, not just soft tissues. You can do it on firm and rubbery tissues as well. So I'm going to show you some examples of different cases. Here, before I get into that though, this here is a high magnification view of some gray matter. This is about 400 times magnification, and what you can see, I want to show you what normal tissue looks like before we go to the abnormal. And here is a neuron. This large cell is a neuron. This is an astrocyte. This is an oligodendrocyte, and this is a capillary. This is a tumor capillary. Or I shouldn't say, I'm sorry, not a tumor capillary. This is a normal capillary with red blood cells in it throughout. This is what normal gray matter looks like. These are all the different cellular components of normal gray matter. This is normal white matter with lots of oligodendrocytes and lots of astrocytes scattered throughout. No neurons in the white matter. And the white matter, yeah, we call it white matter, but in this special stain, it looks kind of pink. Now, if you take that white matter and you smear it out, okay, on a glass slide, this is what it's going to look like. This is what normal white matter is going to look like, progressively going to higher and higher magnification. You can see all these capillaries. This is the capillaries. And these are little oligodendrocytes here, and you got some astrocytes there. That's what normal white matter looks like. Now, if you smear gray matter, this is what normal gray matter looks like with neurons. These big guys here and here, those are neurons. That's what they look like on screen. So burn those images into your head because you're going to start to see a lot of really abnormal stuff. This is a case one of a very unfortunate 45-year-old man who had a bad brain tumor. Now, this is an MRI, and you can see this is a side view of the patient's brain, and this is the tumor. So just to give you some orientation, this is his eye, this is part of his nose, his mouth. So this is an MRI showing what's called the sagittal or side view of his brain. And it's a section through the brain. Now, you'll see there's white stuff around the edge of the tumor. What this is contrast agent that's being taken up by the tissues in that part of the brain. So the patient's been given IV contrast dye, and it's accumulating preferentially in certain parts, particularly in the tumor of this patient's brain. That sort of thing, the buzzword we would call it is contrast enhancing, or in this particular case, ring enhancing. And that's generally a bad sign. The ring enhancement usually means a high-grade glioma. So this is the intraoperative smear preparation from the biopsy that the neurosurgeon gave me. And as you can see, compared to that, this is a lower power view compared to the lower power view of the white matter. Really, really nasty stuff. Lots and lots and lots of blue cells here. Very proliferative. Lots of big, tangled, complicated blood vessels. These are blood vessels. You can even see the individual red blood cells coursing throughout here. And the tumor itself, the cells themselves look really wild and atypical. There's a lot of variation between cell to cell. They're bad-looking, nasty things. And other parts we actually saw, this is a mitosis. This is a mitotic figure. This is a tumor cell that's caught in the act of cell division. It's producing two daughter cells. Under normal circumstances, you would not see any mitosis in the white matter whatsoever, or even in the gray matter. But when you see it in a case like this, it's a red flag that you're dealing with a high-grade tumor. So the intraoperative diagnosis I gave to the neurosurgeon was high-grade glioma. Gliomas are the most common primary tumors of the adult population. If you're going to have a tumor that grows from the brain as opposed to spreading to the brain, glioma is most commonly going to be it. Unfortunately, they're usually high-grade. So on permanent sections, we had the blood vessels here. These are the blood vessels. They look a lot different than they did on the smear, but it's the same thing. These are the blood vessels. And these are really wild, atypical looking cells. These are nasty, very, very ugly cells. And we see here a mitosis. There's lots of them throughout this tissue. So unfortunately, the diagnosis was glioblastoma, which is a grade 4 tumor. That's the highest grade we have, and it's also the most lethal. Now, they're not all bad news. This is a case of a 50-year-old woman. By the way, I've changed the ages and genders of the actual patients so as to further preserve anonymity. This is another side view of the brain, and here you can see the tumor is actually down here. And it's contrast enhancing, but it's enhancing all the way through. It's not just a ring enhancing tumor. It's all the way through the entire tumor. And if you look very, very carefully, and it takes some training to understand this, the tumor itself is not actually arising from the brain per se. It's arising from the membranes surrounding the brain, also called the meninges. And so instead of growing out of the brain, it's actually pushing into the brain. Now that's a pretty serious thing because it's still causing, as you may imagine, a lot of symptoms. But in a case like this, 95% of the time, it's going to be a tumor called a meningioma, a tumor arising from the meninges, which tends to be a very low-grade favorable tumor. So here's the smear preparation. You can see all the tumor cells, and at first it might be scary because you might think, geez, it looks just as bad as the glioblastoma did. But looking more carefully, you can see that there's actually a lot of uniformity. All the tumor cells look more or less the same. The nuclei, these little blue guys, they're very regular and monotonous and kind of boring. And actually another thing we'll see is, especially you can see this on a smear, is that the tissue, the cytoplasm, the pink stuff, as part of the cells, stretches out. We call it pulled taffy. In neuropathology, when you talk about pulled taffy, an intraoperative diagnosis, that's a buzzword for a meningioma. Other features include this circular structures of cells, these circular collections of cells. They like to form these little balls called whorls, W-H-O-R-L-S, whorls. That's just what meningiomas like to do. And you'll actually even see little concretions. This is a little bit of mineralization, a little bit of calcification going on at the center of this whorl. Many meningiomas have so many of these little calcifications they can actually feel crunchy or gritty if you rub it between your thumb and forefinger. So the intraoperative diagnosis was meningioma, and the neurosurgeon knew, okay, if I take this whole thing out, the patient's probably in good shape. With the permanent sections we got a day or two later, you can see really nice architecture here, nice and smooth, lots and lots of cells, but there's also a lot of cytoplasm to go with the cells. That's generally, if you see a lot of pink to go with the blue, that's generally a sign we're dealing with a lower grade tumor. And here here's a whorl right here, which has actually got a pretty good calcification going on right there. And that makes the diagnosis of a meningioma. In this case, it was a grade 1 meningioma, which is the lowest grade of meningioma. And it generally means that if they got the entire tumor out, the patient's got a 95% chance of having been cured. It probably won't come back, and she probably won't need radiation or chemotherapy. All right, third case. 63-year-old woman. This is another side view of the brain. And if you look very carefully, you might not see anything. You see, gee, there doesn't look like there's any tumor here. Well, there isn't a tumor. The tumor is actually not in the brain itself. It's actually right underneath the brain in a gland called the pituitary gland. In fact, the tumor is right here, and it's pushing on the normal pituitary. It's pushing it upward a little bit. It's kind of a nice view here because actually not only can you see the cerebrum, you can see the corpus callosum here. You can see this is the cerebellum. This is the midbrain, this is the pons, this is the medulla, and this is the spinal cord. Now this tumor, 99 times out of 100, when it looks like this, in this kind of a setting, it's going to be a benign tumor of the pituitary called the pituitary adenoma. So, I like pituitary adenomas for two reasons. First of all, they tend to be a lower grade tumor. The outcomes tend to be kind of good, especially compared to a glioblastoma. But also on an intraoperative preparation, it's really easy to do. I don't even have to do a smear. I don't have to take the tissue and smear it on a glass slide. I can just take the tumor tissue and touch it onto a glass slide. Because normal pituitary tissue, if it's got a normal architecture, the cells like to stick to each other and don't like to touch off. So they'll stay stuck to the glass slide, or they won't stay stuck. They'll stay stuck to themselves and will not touch off on the glass slide. On the other hand, a tumor, a pituitary adenoma, tends to be looser, it's lost normal tissue architecture, and won't stick to each other very well. If you touch tumor tissue onto a glass slide, it'll touch off and stick to that glass slide and stay there. So that's what we've done here. Each little blob of cells that you see here and here and here at low magnification, that's where I touched the tissue off directly with a pair of forceps, just touched it right onto the glass slide. It's super fast. Goes through the staining, and at higher magnification, you can see wall-to-wall cells. Now, again, that might look scary, but just like in that meningioma, if we look very, very carefully, we see that the tumor cells themselves are very monotonous. They're very bland. They're not really wild-looking. There's no mitoses. There's no necrosis. There's nothing else that looks scary going on. It's just a bland pituitary adenoma. And so that was the intraoperative diagnosis. Going to permanent section is actually a lower power. It looks a lot like that meningioma, but this is a pituitary tumor, and that's location in large part dictates a lot of the diagnoses. And we can also, if we needed to, we could do special stains and other things to prove it. But in this case, the histology, the appearance of the tissue under the microscope is good for the diagnosis of pituitary adenoma. Now, I've shown you a few cases already here of definitive diagnosis where the diagnosis was very easy intraoperatively, and the final diagnosis matched the intraoperative diagnosis perfectly. This is a case where it was a little trickier. 48-year-old man who had this funny-looking kind of subtle lesion in the brain. It's easily missed. Now, they gave the patient contrast dye, but this lesion here, this piece of tissue, did not really take up the contrast dye very well. There's a very slight wisp of white here and there. It didn't take up the dye very well. So it wasn't at all clear what this thing was. So when they went and biopsied it, I had a very open mind. I had a very broad differential diagnosis in mind. So this is at higher magnification. And you can see all these really wild, atypical, bizarre-looking cells. You can also see all this pink, schmutzy crud in the background. It looks really grungy. So what we're seeing here is necrosis. This is all dead. And then these are all just really bizarre, atypical-looking cells. Now, I looked at this, and I thought, well, this looks like a high-grade glioma, kind of like that first case I showed you. But the tumor did not, if this really is a tumor, it did not contrast enhance very well. There was very little white. That makes me wonder, geez, could it be something else? The other thing is, just looking at these cells, they were so bizarre and so atypical. They were so out there. I've actually seen cases of viral diseases, for example, viral encephalitis, that can produce cells that look exactly like this. Now, you might imagine a viral infection of the brain is going to be treated a lot differently than a brain cancer. So this is a case where it really helps to have good rapport with your neurosurgeons, and I'm on a first-name basis with our main tumor neurosurgeon. I called him up in the OR and I said, look, Tom, for sure you've got lesional tissue. You've got diagnostic material here. I'm not 100% sure what it is, but I think it's probably high-grade glioma, but I'm not 100% sure. Is that okay with you? Or do you really need something more definitive? Because if you needed something more definitive, maybe I'd call some of my colleagues in. We could try to come up with some kind of consensus. But he was okay with it. He said, no, as long as I know I've got lesional tissue, we can work it up later, over the next couple of days using more sophisticated methods. So that was my diagnosis. That's what I wrote down on the sheet. I said, lesional tissue obtained, and we're going to defer the diagnosis to those permanents, i.e. the permanent sections. So here's the permanent section I got a day or two later, and you can see those very same bizarre, atypical cells. And through some additional workup, some genetic studies that took a few more days, I was able to prove that this is actually not virus, but it actually is a special subtype of glioblastoma called giant cell glioblastoma. It's got the same bad prognosis as regular glioblastoma, but it's got these extra large cells that can mimic other types of non-neoplastic diseases. So that was a little bit complicated, but again, having a good rapport with a neurosurgeon helped a lot. Now, having not just the radiology, as I've shown you, I always like to look at the radiology before I do an intraoperative diagnosis, before I do a consultation like this. Otherwise, I'm flying blind. I especially want to know the patient's history. This is a great example of where you needed to know the patient's history. I look at that lesion right here. It's a ray-enhancing lesion in this 39-year-old guy. It looked exactly, radiologically, looked exactly like that case I showed you from case 1, that ray-enhancing lesion. But in this case, we knew that this guy was HIV positive, and not only was he HIV positive, he had full-blown AIDS. In patients who've got a bad immune system, either because of AIDS or if they've had an organ transplant, like a liver transplant or a lung transplant, and they're on anti-rejection medications, there's all sorts of diseases that can affect the brain and look a lot like a tumor. They can have all kinds of bugs and other infectious diseases in particular will go after the brain, and radiologically are indistinguishable from brain cancer. So they gave me the tissue for biopsy, and we went right to a frozen section in this case on it. This is a lower power view, and you can see that the tissue is all kind of breaking apart. That's because it's a very, very necrotic. Necrotic tissue, dead tissue, doesn't want to hold together very well. So when you cut through the blade, there's just fragments. And you can see it's a progressively higher power. This is what we're seeing here. It's mostly dead stuff. This is all dead tissue. You got these little flecks of blue, these little flecks of schmutzy blue junk. Here as well in particular, we're seeing some things, and I'm looking at this one especially because I knew the patient's history. See, if I didn't know this patient had HIV and actually had full-blown AIDS, I really would be at a loss to explain what this is all about. But looking at the patient's history and correlating it with all these findings, I'm like, boy, this has got to be a parasitic infection called toxoplasma. Now, I called into the OR and said, look, for sure you've got diagnostic tissue, and I really think it's probably toxoplasma, which is a parasite that infects the brain, especially in immunocompromised patients. And they were okay with it. They're like, okay, because this was just a special needle biopsy. They weren't planning on taking the entire tissue out. This wasn't one of those resections. They were just doing a little needle biopsy to make sure that they had diagnostic tissue to prove what the disease was so they could treat it. So on permanent sections we got a day later, you can see this is the entire biopsy. This is all we got. This is 3 fragments of tissue, each of which are about 3 millimeters across in length and maybe a millimeter or less in width. Very, very small pieces of tissue, but that's what we're used to dealing with in neuropathology. So as we go at higher magnification, we can see the exact same types of things we saw in the frozen section. We saw lots of necrosis, lots of dead stuff. And we're seeing all that junky debris, the little flecks of blue all over the place. And the more I looked at them, I'm like, boy, I think these isn't just debris. I actually think these might be little parasites kind of just floating around in that dead tissue. And this in particular, things like this and this look like dead toxoplasma cysts to me. But I found out that the patient, they had already kind of suspected it might be toxoplasma, so they were treating the patient ahead of time with antibiotics. And that would explain why everything was so dead. So I was able to do then a special stain. It takes like an overnight to get the stain. And the details are not important. The bottom line is that this stain produces, when anything you see that's brown is toxoplasma parasite. Anything that's not brown are the patient's own cells. And again, this is not the kind of stain you can do rapidly. You can't do that in the operating room. It takes like 12 hours or longer to get it done. But this sort of stain is very important because it allows us to prove that indeed this patient does have toxoplasmosis, which by the way is a parasite that you get from handling infected cat feces. That's why we strongly encourage women who are pregnant not to change kitty litter, because even though their own immune system might be able to handle the parasite, I guarantee you that baby's immune system cannot. And I've seen what toxoplasma can do to a fetal brain. It's absolutely tragic. So stay away from kitty litter if you happen to be pregnant. Now, I've shown you a bunch of brain and tumors in the head, but we can see tumors in the spinal cord too. That's part of our territory that we cover as neuropathologists. For example, this is a 34-year-old woman who had some problems with her lower back, and this is an MRI, a side view of her spine. What we're seeing here is the vertebral bodies of her spine. So this is all bone here, here, and here. Those are all, that's bone. The dark areas in between, that's all cartilage. On this side, we're seeing more bone, and then we got some muscle here. Those are back muscles, and then this is all subcutaneous fat tissue. This is fatty tissue underneath the skin. Here's the skin right here. So this is lumbar spine. This is in the sacrum, and this is the tailbone. This is the tailbone right here. Now this is the spinal cord. Normally the spinal cord is very dark on this particular type of MRI. And this patient was given contrast dye, just like we saw in some of those other cases. And in this case, the contrast dye highlighted this sausage-shaped tumor sitting at the very tip of her spinal cord. The actual spinal cord in an adult stops right around here. The rest of this is empty. It's not just empty space, but it's, if you look very carefully, you can see these wisps of white. And these are little nerve rootlets coming out at the base of the spinal cord. but the spinal cord normally terminates right around here. And in this case, this woman's case, she had a tumor growing at the very tip of it. Now, 99 times out of 100, a tumor with that radiologic presentation is going to be something called a MYXOPAPILLARY EPENDYMOMA. Now, I know it's a mouthful, but it's actually, if you had to have a tumor of the brain or spinal cord, that's not a bad one to have, because it's a grade 1 tumor, and if they can get the entire thing out during the surgery, the patient's probably cured. It's not going to grow back. So that's the tumor. Now, on the smear preparation I did, you can see it's got this very, to my eye, kind of pretty architecture. It's really splayed out quite nicely. And as we go to higher magnification, we actually get a little sense of the architecture of the tissue. In particular, what we're seeing here is a blood vessel that's surrounded on both sides with tumor cells, and these thin pink processes extending from the tumor cells to the blood vessels. These thin pink processes, this arrangement of tumor cells sending these pink processes down to the blood vessel is very characteristic of ependymomas. And based on this, as well as the radiologic findings, and a few other findings I saw in the smear, we were able to confirm the diagnosis excuse me, of MYXOPAPILLARY ependymoma. Which is a good thing, because when the surgeon hears that intraoperatively, he's like, oh, great, I better make sure I excise the entire tissue and take great pains to take that tumor out, because then I've cured the patient. So here's the tissue, low power on permanent section, that nice paraffin-embedded section that takes a day or two to process. And here you can see the same type of arrangement. You got tumor cells surrounding the blood vessel with these pink processes coming down. You can see it in another spot here with the tumor cells here on either side. Here's the blood vessel. There's a longitudinal section through the blood vessel. You can see all the little red blood cells and the pink processes coming from the tumor cell down to the red blood, down to the blood vessels, confirming the diagnosis of MYXOPAPILLARY ependymoma. All right, this was meant to be the video that I was supposed to do. I'm sorry it didn't work out. For some reason, I didn't project. But the video I did was actually of a lung cancer that had metastasized to the patient's brain. And this is actually the smear preparation of that lung cancer. So what you can see here is the lung cancer is here. Actually, there's islands of lung cancer all over the place. And this is the patient's brain tissue that's being beaten up pretty badly by the lung cancer. As we go to higher magnification, the cells are in these kind of tight sheets. They're very cohesive. This is a sign that's actually a particular type of lung cancer called squamous cell carcinoma, which is more common in men than women. So it fits the history. Now, in frozen section, you can see the same kind. It looks a lot different, doesn't it? I mean, this is also tumor, so is this. And here's an interesting thing. If we go to higher power in particular, you can see all these wacky-looking cells. These are not tumor cells. Excuse me. These are actually non-neoplastic, non-tumor brain cells, in particular astrocytes, that are reacting to the infiltrative cancer around it. This is a very, very important point, because, and I try to impress upon all of our trainees this, just how wild, how scary, otherwise non-neoplastic tissue in the brain can look under certain circumstances. We can say exactly the same kind of changes, for example, in a virus that's infecting the brain, if it's near an abscess, or if you're or stroke. A tissue near a stroke will look exactly like this. A demyelinating disease, like someone's got multiple sclerosis, cells near the areas of demyelination are going to look just like this, and they can look a lot like a cancer. So it takes a lot of practice, and even still, I mean, even after I've had several years now, I've had a lot of training and several years of experience as an attending, it's still very scary when you start seeing cells like that, because they're, even though they look cancerous, they're actually not. All right, so I'll spend a few moments here at the very end to talk about something that's really exciting, near and dear to my heart, and that's digital neuropathology. Excuse me. This is an area of innovation that's really transforming not just neuropathology, but all of pathology. And it's going to affect, if it hasn't already, it's going to affect how your care is given. So here's the thing. Brain tumors are operated on, neurosurgery cases are done at hospitals all over the country, right? Well, nationwide, neuropathology is actually not a very large field. For example, I was just at our annual neuropathology meeting in North America, and maybe there's 200 or 300 people total there who are all board-certified neuropathologists. Furthermore, we only are training in North America, between the United States and Canada, maybe around 15 or so new neuropathologists every year. That means that there's actually kind of a shortage of neuropathologists because it's such a hyper-subspecialized area. Now, it gets a little tricky, though, because not every hospital, therefore, can have one on staff. But any hospital that's doing neurosurgical procedures is going to end up with brain tumors that they want worked up. Generally trained pathologists, pathologists who specialize, or who really don't specialize, but maybe just have more broader training, or specialize in diseases of the lung or colon or something, or breast, they're not comfortable handling brain tumors because it's a completely different animal. It doesn't look like anything else that is seen in other parts of pathology. And neurosurgeons certainly don't like their cases being handled by somebody who's not a subspecialist. Telepathology is a very good way for hyper-subspecialized people like myself to extend our coverage beyond just our immediate hospital. We can do now and provide expert intraoperative care to hospitals that they don't even have to be in our state. Excuse me. They can be across the country. They can be across the ocean. In fact, a lot of times now we're starting, people are starting to do it at different institutions. They're starting to do coverage of, say, late-night frozen sections in Australia while their own neuropathologists are asleep, and vice versa. And the way we're doing it is through these robotic systems here, where the technician who's on site prepares the slides and loads them in these little chambers here on a motorized stage. This is a microscope with a very special motorized stage and a camera that can be controlled by remotes. So here, for example, would be a website. As long as you know the proper IP address to log into, you can control this from any broadband connection anywhere in the world. You can do it on a tablet computer if you wanted to. You can control that microscope by remote through these special keys on the website and look at the tumor in real time. You control magnification, control the location, and you can see these whorls all over the place. For example, in this case, which is a meningioma. Another innovation is virtual slide technology, and this is really an example of how broadband access has revolutionized what we can do, because now you can send larger files very quickly over the internet than you ever could before. A virtual slide is an entire slide that's already been scanned and digitized and made into a visual file. Here, for example, I'm about to click, and I don't know if this is going to work or not because it's actually going to click to another site. Can everybody see that? Well, I'm hoping you can, because what I've just opened up here is a virtual slide file that is not actually located on my computer. This file is located on a server at the University of Pittsburgh as we speak. I just opened it up and instantly I pulled it from the University of Pittsburgh, even though I'm here in Kentucky. It's a 6 gigabyte file, very, very big file, but you can see I'm manipulating this in real time. You can see my mouse is grabbing it. I'm changing the magnification. I can use the finger wheel to move it up and down as far as magnification goes. I can jump all over the place. And what I'm looking at right now, for example, is actually a virtual slide preparation of a glioblastoma. This is a glioblastoma that's been smeared out. So you can see how quickly it loads up. Very, very, very fast. 5 years ago, especially 10 years ago, this would have been impossible. Way, way, way too big a file. Couldn't do it efficiently. Excuse me, online. All right, that's the virtual slide. So now let's go to the permanent slide. Here's the permanent slide right here of that very same glioblastoma. Again, it's 5 gigabyte file, actually physically located at the University of Pittsburgh, but I'm able to easily and rapidly access it here in Lexington, Kentucky. And I mean, this could just as easily be in China or Japan. I mean, you could have this file to be located anywhere in the world. As long as you have a good broadband connection, you can access it and render diagnoses pretty effectively. So it's really changing how we're practicing medicine as this becomes more and more widespread. So in summary then, first of all, as you can see, an awful lot's going on behind the scenes during neural surgeries. And pathology is a very humbling line of work. I mean, even though I spent years training in it, and I've already been a practicing physician on my own for several years now, I still see cases all the time that I'm like, or just stretch my knowledge base, and I really have to be careful and cautious about what I'm calling. And I have no hesitation about enlisting the help of colleagues either here at the University of Kentucky, or we're a very collegial group of neuropathologists. So if we don't see something we're comfortable with, we'll send it to somebody else to get a second opinion. All going on behind the scenes, the patient never knows what's going on. And as you can see, we're undergoing massive changes, not just on this virtual digital slide stuff, but even the molecular testing that we do to enhance diagnoses and prognoses. There's all sorts of things that are absolutely revolutionizing how pathology is practiced. It's already a massively different type of field than it was just even 10 years ago. So I have to finish with this cartoon because it's kind of a quintessential neurosurgery thing. It's a favorite of neurosurgeons and neuro-oncologists all over the world. Gary Larson, of course, is the far side from quite a bit, probably about 20 years ago now. But it's a classic. All right, I'll take any questions.
Okay, thank you so very much, Dr. Horbinsky. That was a great slideshow, and we will talk offline about the video issue we encountered. I think we've figured it out, but we'll try to find a way to make that available for folks. We have had a couple of folks ask
if you figured it out, I could actually run it again if you want.
Yeah, it's not going to work, unfortunately.
Oh, okay.
What it is the speed of the video is faster than what the platform can manage. So, but we can figure it out offline.
Very good, very good.
Yeah, thank you so much for doing this for us. We do have some time now for a few questions. I can see them arriving, and folks have asked a little bit ago about whether or not this webinar is being recorded. And again, yes, it is being recorded today, and we will post it shortly to the ABTA website. For those of you who may not have yet had a chance to visit the ABTA website, certainly would encourage you to do that. It's www.abta.org. If you go to the Understanding Brain Tumors tab at the top of your screen, and then to the Anytime Learning section, all of our webinars that we've shown to date are posted there for your viewing pleasure. So the first question today comes from Regina, and Regina asks, is a meningioma considered brain cancer?
That's a good question, actually. It touches on something that can get a little controversial. For example, most of the time we think of tumors like elsewhere in the body as either benign or malignant. Well, in the brain, I don't like calling something malignant versus benign, because really any tumor in the brain or in the meninges around the brain, it can be very serious. And we prefer using terms like low grade versus high grade, or medium grade, intermediate grade. Now, meningioma, I would call a low grade tumor. Most of them are low grade tumors, and technically it's a neoplasm. If you wanted to call it cancer, I don't know. That's a tough call, because a grade 1 meningioma is usually curable. On the other hand, a grade 3 meningioma, which is a high grade meningioma, is a nasty piece of work, and that will kill you just as readily as a glioblastoma will. Grade 3 meningioma is definitely what I would call cancer or malignant. But then there's cases that are kind of fall in between. There's these so-called grade 2 tumors, or even very rarely a grade 1 tumor that you think for all the world is going to do well, and for some reason keeps growing back and progresses to a higher grade. So technically speaking, I suppose you'd have to call any of that stuff brain cancer, but just because it's cancer doesn't necessarily mean it's a death sentence. Meningiomas in particular are a very mysterious kind of tumor, and we're learning more about those every day. But yeah, it's a good question. But like we talk about benign versus malignant brain or spinal tumors, but in my opinion, I don't like those terms because it loses all relevance in the brain.
Thank you. Our next question asks, when a cancer metastasizes to another part of the body, for example, to the lung or to the brain, is it still considered lung cancer, or has it now become brain cancer?
No, it's still lung cancer, absolutely. It's still lung cancer. It still carries the same genetic mutations and everything that the original lung cancer did. Yeah, it's absolutely still lung cancer. or brain cancer. In fact, lung cancer is the most common kind, especially in the state of Kentucky here where so many people smoke. About half of all the metastatic tumors we see to the brain actually are coming from lung.
Thank you. The next question comes from Richard, and Richard asks, can an intraoperative smear distinguish between a low-grade glioma and a focal cortical dysplasia? I'm sorry, I was having a hard time.
Cortical dysplasia, oh yeah. That's actually an excellent question. That's one of those kinds of cases that gives me gray hair because it is really difficult to tell the difference between cortical dysplasia, which is what that basically means is a malformation of the brain. It's not a tumor, although it can cause seizures. So very often they'll map the seizure causing part of the brain, right? You know, with the electrogrid mapping and all that, and then they'll take out whatever part of the brain seems to be defective, and hopefully that'll cure the patient's seizures. Well, very often brain tumors will also cause seizures, and it can be hard to distinguish, very hard to distinguish between a low-grade glioma and a cortical malformation like that. So what we'll do in cases like that, and I've already gotten to the point where I'm pretty cautious, and I'll just tell, again, the neurosurgeon, look, you've got lesional tissue. I can't tell if it's a neoplasm or if it's a malformation. Let me do some genetic testing, because we actually now have some pretty good genetic tests that can reliably discriminate between the two, but you can't do them fast. It can take the better part of a week. And he's on board, all the clinicians are on board with that, and so they're willing to wait a few more days to get really reliable results.
Thank you. The next question comes from Thomas. Thomas asks, are most brain tumors fairly consistent as you look at the slices through them, or do they differ in consistency at the boundaries or in the middle?
That's another excellent question. Brain tumors, well, I'm going to assume he's talking mostly about gliomas. Are they? Yeah, I'd say most of the time they are consistent, although we're learning now that there's a lot, especially at the subcellular level, at the genetic level, there's actually a lot more heterogeneity or variability within the tumor. So sometimes even areas of the tumor that look the same under the microscope, if you go from one area versus another, or you go deeper, they can have slightly different genetic alterations. And that might explain why it's so hard to treat these doggone tumors, because any therapy you give the tumor might only kill 80% or 70% of the tumor cells, and then the other 30% just grow back. So, yeah, that actually, even if under the microscope they look, sometimes they can look a little different depending on the area for sure. But what we're finding is they really are different from area to area based on their genetics. These are not uniform tumors. They actually have a lot of diversity. The other thing that's important to remember too is as we're talking about sectioning deeper into these tumors, for example, if somebody has a ping pong ball sized glioblastoma in their brain, even if that's all you see radiologically, you can be rest assured that there are infiltrating individual tumor cells throughout that patient's entire brain. Every single part of that patient's brain is going to have handfuls or just a few microscopic infiltrating tumor cells. That's one of the reasons why these tumors are so hard to treat. You can never get the entire tumor out.
Thank you so much. We have another question from Calissa. She asks, how common is it to have the intraoperative frozen slide diagnosis and the final pathology report diagnosis differ?
Well, let's see. I would say probably our concordance is over 95%, meaning maybe about 1 in 20 there's a discrepancy. And the discrepancy is almost always due to samplings. As I mentioned before, you could take the piece of tissue, but you don't want to use it all up on a frozen section or a smear, so you just take a little snip of the tissue and hope that that's representative of the rest of the stuff. But a day or two later, when you get the permanent sections, you might see an area of tissue. You're like, oh, geez, if I had seen that under the microscope during the intraoperative consultation, I would have changed my diagnosis. But it doesn't happen that often, although I will say the cases where it does happen, they do tend to stick in my craw for a long time.
Thank you so much. We do still have a few remaining minutes here if you'd like to ask a question of Dr. Craig Horbinski. You can go ahead and type it on your screen. We've got about 5 minutes remaining if you have a question you'd like to ask. While we're waiting, though, for some additional questions to come in, I would just like to remind folks about our ABTA Care Line, which is staffed by licensed healthcare professionals. If you haven't yet had an opportunity to call us, we would certainly encourage you to do so. Our phone number is 1-800-886-ABTA, and we're happy to help you find the resources, education, and support that you need as you go through the brain tumor journey. Additionally, I did want to take a moment to provide a shameless plug for our upcoming ABTA Patient and Family Conference that's going to be here in Chicago. There is information about the conference up on our website. We're certainly looking forward to lots of folks attending. We'd love to have all of you on the line today participating in this webinar attend as well. We've got a great program this year, and we'd love to see you here in Chicago. It looks like we don't currently have, here I have one more question I spoke too soon. Thomas asks, how is it that a low-grade oligodendroglioma in 2003 is looked at in 2010, is then looked at by someone else and is diagnosed as grade 3 oligoastrocytoma after a recurrence of the tumor? Is this common?
Well, all right. So in other words, my understanding of the case is that in 2002, it was a grade 2 oligodendroglioma, but then the thing ended up growing back, as they usually do. And now it's progressed to a grade 3 tumor. That's actually very common. About 2/3 of grade 2 tumors will eventually grow back as grade 3 or grade 4 tumors. That's just the natural progression of the disease. They grow back as higher grade, more aggressive cancers. Now, as far as this whole oligodendroglioma versus oligoastrocytoma business, that actually touches on a pretty interesting point, because right now we're still using criteria based strictly on morphologic examination of the tissue, i.e., what does it look like under the microscope, to distinguish between something that's an astrocytoma versus an oligodendroglioma versus something that's both, oligoastrocytoma. And without getting into all the details, the consensus is slowly emerging that that's not such a great way to go. It's much more accurate to just strictly test the tumor for certain key genetic mutations. For example, co-deletion of 1P and 19Q, or ATRX mutation, or P53 mutation. I know it's all very technical, but it's just giving some of the key genetic hallmarks. And if it's got, say, co-deletion of 1P and 19Q, it's an oligodendroglioma, period. If it's got ATRX or P53 mutation, those are astrocytomas, period. And just to keep them more evenly split and not sweat so much these morphologic details. Because I'll tell you, that's the one thing that the oligoastrocytoma diagnosis in particular is so subject to inter-observer variability. So somebody who trained at one institution that loves the diagnosis can look at that and say, oh, it's an oligoastrocytoma. A place like where I trained, you know, we did not like that term, and so we tried to put things into an oligodendroglioma or an astrocytoma box. And you can show, and studies have shown, you can show very, very good board-certified neuropathologists the same tissue, and one will say it's an oligodendroglioma, one will say it's an oligoastrocytoma. And the genetic testing has one of the advantages of the genetic testing is it takes away all of that subjectivity, and it makes the diagnosis more objective and more consistent. So in that particular case, if it's a grade 2 that progresses to a grade 3, it's, as long as it had co-deletion at the beginning, which my guess is it probably did, that's why it took 7 years or 8 years to progress. If it had 1P19Q co-deletion, it is an oligodendroglioma, period. But now it's a grade 3.
Thank you.
Sorry for the long answer, but actually it's a great question because it touches on a highly controversial aspect of neuropathology that I expect is going to change a lot in the next 5 to 10 years.
Absolutely. The question and answer portion is very, very important. So we're grateful for these great questions from those who are participating today. We do have another question that has just arrived from Regina, and she asks, can a meningioma change into another type of brain tumor, such as a glioblastoma?
No, they don't. They're completely different tumors. They arise from different tissues. Now, there are times when, for example, a meningioma can start to look a little bit like a glioblastoma under the microscope, or you can see a glioblastoma start to look a little bit like a meningioma, especially high-grade meningioma, but they're not. If you look at the genetics, they're completely distinct tumors. They're driven by different mutations, and the treatments are different.
Thank you. We have a question from Stephen. He asks, when a meningioma has swelling, how is it distinguished from hydrocephalus?
Well, swelling of a meningioma. Now, let me answer that. Meningiomas, generally, they get big, but to say they swell, what they can do is induce a lot of, I think what he might mean, if I'm getting this correctly, is inducing swelling underneath. So sometimes when those meningiomas press on the brain, they can cause the underlying brain to swell, which kind of makes sense if you think about it. There's a big, big difference between that and hydrocephalus. Hydrocephalus basically means there's a disruption in the flow of cerebral spinal fluid throughout the brain. So cerebral spinal fluid is a special fluid. It's actually an ultrafiltrate blood. And what it does is it cushions and nourishes and protects the brain from shock. So if you hit your head or something, your brain's not banging around too much inside your skull. The cerebral spinal fluid helps cushion you. But there are certain spots along the cerebral spinal fluid flow that can be easily blocked off. And if it's blocked off, then you can get a backup of, it's basically like flooding of the brain, really. So the brain will start, the ventricles within the brain will start to expand because they're taking on all this fluid and they can't get rid of it. And that's hydrocephalus. Now, sometimes a meningioma actually can't, if it's in the wrong place, a meningioma, just like any other tumor, can cause hydrocephalus. It can block off certain parts of the cerebral spinal fluid flow. And that might actually sometimes be how a tumor presents. So sometimes a patient might be just fine, and then they get dizzy or nauseous, or they just fall over. You do a scan, and you find out, oh, they got this tiny little tumor, but it's just in the right spot, and it's blocking the cerebral spinal fluid flow. And that's actually what caused the patient to seek medical care.
Thank you. The next question comes from Thomas, and hopefully I'm going to be able to phrase this correctly, but he asks, how different are oligoastrocytomas without deletions and GBM?
How different are they? Okay, oligoastrocytomas without, okay, that's, well, let's see. If you have, how to put this? If you have a grade 2, and this is the emerging consensus, again, from a lot of the clinical trials that are being done and some of the retrospective studies, if you have something that looks kind of like an oligodendroglioma versus an astrocytoma, and they look, it's a little bit of both, but it does not have co-deletion, then it's going to act like an astrocytoma. So if it's a grade 2 astrocytoma, it's going to behave on average, and there's a lot of variability, but on average it's going to behave a little bit more aggressively than a matched grade 2 oligodendroglioma with co-deletion. Now on the other hand, and this is something very important, if you've got a grade 3 tumor and it does not have co-deletion of 1p19q, and it does not have another mutation called IDH, which is a hot new topic in neuro-oncology, if it has neither of those things, but it's a grade 3 tumor, on average, the survival is just as bad as if you had a grade 4 glioblastoma. And it's data like that which is showing to be highly reproducible from study to study across all different continents. That's the kind of data that's really going to change how we classify these tumors. Because if you have a grade 3 tumor that has neither co-deletion of 1p19q or an IDH mutation, your survival is just as bad as if you had a straight-up grade 4 glioblastoma, which is unfortunate, but at least it helps us target these different tumors better for therapy.
Thank you so much. It is now 3:02 Central Time. We do have a little extra room for some additional questions if anyone would like to ask anything else of Dr. Craig Horbinski today. We'll take just a brief pause here to see if any additional questions come through. Well, it looks like that may have been our last question today. So if that is the case, we'll go ahead and begin to wrap up our program this afternoon. Again, I apologize to the participants online. We'll figure out how to handle the missed video footage. I was certainly looking forward to showing that. We'll figure out how to make that available to all of you later on. I can talk with Dr. Horbinski offline and we can get that figured out. I do have contact information for all of you, so we can be sure to let you know. While I was chatting just now, we did have one additional question come in from Jason, and Jason says, you mentioned treatment. What kind of treatment is typical for these type of tumors?
Well, if you have a low-grade tumor, and by that I mean a grade 1 tumor, the general rule is that you just try to get the entire tumor out if possible, and then you leave the patient alone. You might watch them and follow up every few months or so to see if it's grown back. But we try to avoid radiation and chemotherapy in cases like that and just get away with a surgical resection. A grade 2 tumor can vary a lot. It depends entirely on what kind of tumor you're dealing with. But mostly it's resection, a partial resection. If you can get some of the tumor out, if you can get the whole thing out, that's great. But usually you can't. And then it's just watchful waiting to see if and when that thing is going to recur and then progress to a higher grade. As soon as you get to a grade 3 and a grade 4 tumor, that's when we start bringing out the big guns. That's when we bring out radiation, so radiotherapy, which can include either be whole brain radiation or gamma knife, which is a special targeted kind of radiation. So certain chemotherapeutic agents. The only catch is with brain tumors, and this is one of the drawbacks to brain cancer, one of the many drawbacks to brain cancer, is that a lot of the drugs that we use that are pretty effective in other kinds of cancers throughout the rest of the body don't get into the brain very well. They just don't. There's a lot of reasons for it. So we're limited a little bit as to treatment options. The most common drug, for example, for glioblastoma that you're going to get is temozolomide in combination with radiotherapy. That's the current standard of care. But for certain, like these co-deleted, these oligodendrogliomas with 1p19q co-deletion, neuro-oncologists might opt for a different kind of combination chemotherapy called PCV chemotherapy instead of temozolomide with radiation. But again, grade 2, and that's at grade 3 tumor, the grade 3 level. Grade 2 tumors, generally speaking, we avoid radiation, although even that, the consensus is, I don't know about consensus, but there's certain people now who think, well, maybe we should be a little more aggressive in treating either co-deleted tumors or tumors with IDH mutations because they seem to be a little more sensitive to some of these radiation and chemotherapeutic regimens. So if we can hit them at a grade 2 level, then maybe we can do the patient some good. But it's a very complicated choice, a very complicated decision, because as you can imagine, irradiating a brain, just exposing a brain to radiation is not exactly a benign thing. We try to avoid it as much as we can.
Thank you. We've had a couple more questions come in. The next question is from Lon, and Lon asks, what is a gliofibrillary oligodendroglioma? Can you comment on that?
A gliofibrillary oligodendroglioma. I have to confess that particular term I've never heard used before. In fact, I'm quite certain it's not an official term adopted by the World Health Organization. Gliofibrillary oligodendroglioma. Oligodendroglioma, yes, but gliofibrillary is not a descriptor that we use for oligodendrogliomas. So I'm afraid I'm a little bit of a loss to explain that one.
Thank you. The next question is about recurrence. Are all recurrences a grade up? For example, when a grade 1 comes back, does it come automatically, or does it return automatically, and is it considered a grade 2?
No, not at all. In fact, for example, the most common glioma in kids arises in the cerebellum, and it's a pilocytic astrocytoma. Now, most of the time, that particular type of tumor, it's always a grade, well, it's almost always a grade 1 tumor, and even if it happens to grow back, it's usually not that big a deal because it's still a grade 1 tumor, and you can just re-resect it if you have to. But there are certain, like for example, a grade 1 meningioma, right? Well, if that thing grows back, even if the neurosurgeon swears up and down he had a good resection the first time around and the thing grows back, that's a red flag that maybe it's not really such a low-grade tumor after all. Maybe it's a little higher grade. But that still, sometimes histologically, you put it under the microscope, it still looks like a grade 1 tumor. The same thing happens, for example, with grade 2 astrocytoma. Very often, it'll just recur as a grade 2 astrocytoma. In fact, because it's not automatic for it to progress in grade, that's where it becomes really important when if they see the tumor's grown back, especially if it's a glioma, and it was a grade 2 tumor to begin with. They're going to take that tumor out, and they're going to be leaning on me really hard to say, okay, has this thing stepped up in grade? Because if it has, that's going to change the patient management. If I say, yes, now it is a grade 3 or grade 4 tumor, they're going to hit that patient with radiation and temozolomide or some other chemotherapy. But very often, I'll look at it, and I'll look and look and look, and those cases can take me a better part of a day because I'm really looking carefully. And I'll say, look, I don't see any evidence that this thing has progressed in grade. It still looks like a grade 2 tumor. And in a case like that, they're liable to just, they might try to control some of the tumor site with some radiation, maybe. But most of the time, they'll just say, all right, well, we'll just sit tight here and try to hold off as long as we can.
Thank you. The next question is actually sort of a two-part question related to pathology tests. The first part is, do either of the 2 pathology tests you showed available if a neurosurgeon does an awake craniotomy on a patient? And then the second part is, are they being used in awake craniotomy surgeries now?
I'm sorry, could you repeat both of the questions? I want to make sure I got it right.
Sure. The first part asks, do either of the 2 pathology tests you showed available if a neurosurgeon does an awake craniotomy on a patient, and are they being used in awake craniotomy surgeries now?
Okay, you mean the smear versus the frozen. Yeah, we can do them on either kind. It doesn't matter what the surgical procedure is, we can do either one. The only thing that really would dictate whether I do one versus the other is how much tissue do I have, is it soft or is it stiff? Things like that would really affect what I do. But the decision to either go with a smear preparation or frozen section is entirely mine to make. And that's where a lot of that's a product of where you train. Like for example, I trained at the University of Pittsburgh where we did smears on almost everything. But for example, if you're a neuropathologist and you trained at the Cleveland Clinic, you're going to do frozens on everything because that's just their culture there. That's what they do. I mean, both approaches are totally valid. It's just what you're trained on and what you're comfortable with doing. And really the only thing that would limit, for example, and there's cases, for example, if I have a really minute piece of tissue, if I've only got a couple of millimeters worth of tissue, I'll even call the neurosurgeon and say, look, and they don't usually like to hear this, but I'll say, look, this is a really small piece of biopsy. Do you really want me to blow this and waste this on an intraoperative consult, or is this all you can give me? Because there's times when they'll do a little needle biopsy, for example, on an awake craniotomy patient, and they might have a lot of bleeding, or something else happens, a complication arises where they got to stop the surgery. And if that's the case and they can't get me any more tissue, then I'll make the judgment call to say, I'm not doing an intraoperative consult on this thing because I'm going to waste all this tissue. And since this is all you can give me, I'm going to save it for the better histologic analysis that we can do a day or two later.
Thank you so much. We have another great question which asks, do neuropathologists have groups that work together to diagnose tumors similar to a tumor board that meets to make treatment decisions?
Actually, we absolutely do. As a matter of fact, our neuropathology, well, let me back up and say, first of all, it depends entirely on the kind of center you're working at. So there's a lot of places that only are able to have one neuropathologist on staff. Because as I said before, I mean, we're so rare to begin with. But here at the University of Kentucky, we're fortunate. We've got 4 board-certified neuropathologists. So as a result, we're able to have a weekly QA meeting, a quality assurance meeting, where whoever's on service at the time brings all of their cases. We all sit down in a big multi-headed scope, a microscope, where we're all looking at the same tissue at the same time. And we can have open discussions about what the tumor, what it is, what the disease is, what the diagnosis is. And very often we'll have disagreements. We had the same thing at the University of Pittsburgh. Right? We had like 5 board-certified neuropathologists there, and we would have weekly QA meetings. If you have a case, and even in real time, we're a very collegial group here, in particular at the University of Kentucky. If you have a problem with a case, if I see something I'm not sure about, I've got no qualms whatsoever about showing one of my colleagues the same tissue and say, what do you think? And they'll do the same with me. They'll ask me for my opinion all the time, whether I'm officially on clinical service or not. And like I said before, if we get really stuck, I've got a whole host of colleagues at San Francisco or MD Anderson or Florida or Mayo Clinic where I can show them the case and say, what do you guys think? And we're all on a first-name basis with each other, and they'll give their opinions too. So it's an excellent group. But yeah, whenever possible, if you have more than one neuropathologist at a site, we definitely do that sort of thing. And in fact, we also have a multidisciplinary tumor board, which includes not just neuropathologists, but also the neuro-oncologists and the neurosurgeons and the radiation oncologists, and even the support nurses and trainees, residents and fellows will be attending that meeting, and we'll review maybe 10 or 12 cases from the past week that were particularly interesting or problematic. In fact, that's actually going on right now as I speak. One of my other colleagues, one of my other neuropath colleagues is showing cases at the tumor board right 2 floors down from me.
Okay, thank you so much, Dr. Craig Horbinski at the University of Kentucky in Lexington. It looks like that has pretty much wrapped up the remainder of our questions. Again, Dr. Horbinski, thank you so very much for being with us today and for this excellent presentation. We really appreciate your being with us today.
My pleasure. Thanks very much for having me.
Thanks also to all of you who participated and asked some excellent questions. We really appreciate your involvement. We also appreciate your feedback. So once again, following the conclusion of the program today, within an hour or two, you will get a follow-up survey with 5 brief questions. We'd love to hear what you thought of the program today and to get your feedback for additional educational programs we will soon be developing throughout the year. Once again, do take a visit to our website. We're adding new and current information all the time, www.abta.org. We will pause just for a moment now to conclude our recording.